Hello everyone, this is Dr. Farnaz Amoozegar, Clinical Assistant Professor at the University of Calgary and Neurologist at the Calgary Headache Assessment and Management Program. I'm here today to do a live Meet the Expert session on Facebook. And here we have Spinal CSF Canada setting all this up for us, so I want to thank you to them for setting this up. We really appreciate it because we want to raise awareness for patients that have CSF leak and spontaneous intracranial hypotension. So for the next few minutes, we'll just do a little bit of introduction in terms of what got me interested in SIH, but also some of the things that we're doing at the University of Calgary in terms of research, as well as how our process works for seeing patients with spontaneous intracranial hypotension. And then I'd be happy to take questions from you for about 30 to 40 minutes in regards to general questions about CSF leaks or intracranial hypotension. So just to give you a little bit of residency training in Ottawa, and then came back and did a headache fellowship with Dr. Calgary. He's well known in the area of headache and has been a headache expert for quite some time. And it was at that time that I got interested in spontaneous intracranial hypotension because I saw several patients with him where once we made the correct diagnosis and the patient was given appropriate treatment or management, it really changed their lives. So it really made me appreciate, how much we can do for these patients because they can be very disabled at times, and it's very rewarding to be able to provide a better quality of life, or in some cases even provide a cure for patients that have SIH. It's actually one of the headaches where we can say that we can cure a patient for life, whereas that's a difficult thing to say for many of the other headache conditions that we see. In regards to how I got involved in research, and that once I got interested in the condition and started to see more patients, we felt that it would be important to first have a better understanding of the background literature in terms of what's out there already in terms of research for this area, as well as what can we do in terms of guidance for general physicians or neurologists in regards to the diagnosis and management of this condition, because it was not quite clear. So at that time, we started to actually review the literature and came up with a manuscript and guidelines based on all the literature that we had reviewed, which was published in the Canadian Journal of Neurosciences in 2013. And it's become quite useful, especially for Canadian physicians, as a guidance document in terms of the diagnosis and management of spontaneous intracranial hypotension. And now I'm working with the American Headache Society, actually with several experts such as Dr. Shivink, in terms of coming up with guidelines for the American Headache Society with a number of other experts in the US. So hopefully we'll have another updated set of guidelines that can be used by physicians in terms of the diagnosis and management of SIH. In Calgary, we also have a registry that we've set up for patients with CSF leak or SIH, in that any patient who agrees to consent to have data collected in terms of their headache profile, as well as the tests they've undergone, some of the treatments they've undergone. We have a registry set up where we're collecting that data, and we hope that over time when we collect enough data that we can answer some questions that are common. For example, what are characteristics that make a patient respond better to a blood patch versus those that don't respond to a blood patch, or looking at all the different imaging techniques that we can use in SIH, what might be better to use overall. So hopefully we're able to answer some of those questions as the time goes on. And eventually, hopefully if we're able to get some further funding and resources, we can expand this registry out to potentially all of Canada, because currently we just have it in Calgary. But that would be one of our goals, is to make a Canadian registry for patients with CSF leaks or spontaneous intracranial hypotension. And lastly, I just wanted to mention that similar to other centers, CSF leaks or SIH are really something that need to be managed by a multidisciplinary team of physicians and experts. So obviously neurologists such as myself are just one piece of that puzzle, but there are neuroradiologists that are important in reading the scans and doing the specialized types of procedures that we need for patients, such as CT myelograms or digital subtraction myelograms. And then our colleagues in anesthesia, of course, are important for doing blood patches for us, either a blind one or targeted. And then, of course, if patients don't have success with that, then our neurosurgery colleagues often get involved with the repair of CSF leaks in the more complex cases. So really, it is a multidisciplinary team that's required. And so I want to thank all our colleagues who collaborate with us on a regular basis for this to happen as well. So at this time, I think that we can go on to take some questions. And here I have today my assistant, William, who will be reading some of the questions out loud so that you can hear it as well. And then we can go on to take some questions, and I can also pause at any point to reintroduce myself if we have other people joining us. So for those that are just joining us, this is Dr. Farnaz Amoozegar, neurologist and clinical assistant professor at the University of Calgary. So let's go ahead and start with some questions. So William.
Okay, so our first question comes from Krista. What is dural sensitivity and how is it diagnosed? And how is it treated?
Yeah, so dural sensitivity is a difficult and somewhat controversial topic because it's actually not very easily diagnosed. And in some people that have certain medical conditions that predispose them to have dural irritation or damage, such as connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, polycystic kidney disease, or other types of issues that affect the connective tissues. And dura, which is the membrane that overlies the CSF, is a connective tissue. In those patients, they can certainly have various forms of sensitivity or irritation of the dura, but to actually diagnose that is extremely difficult. However, if we have patients that have those conditions, we would certainly consider that as a possible diagnosis. And in terms of treatment, really there isn't something specific that can be used as a treatment for dural sensitivity. But I think that patients just need to be extra cautious if they do have those conditions, or if they're felt to have dural sensitivity or potential for dural irritation, and that we would avoid contact sports or things that might potentially cause head or neck trauma. And patients to be extra vigilant if they do have symptoms that might later suggest a CSF leak, because patients are certainly more prone to have dural tears if they do have sensitivity or irritation to begin with. So it's a difficult diagnosis to make, but I think we have to be sort of thinking about it if patients do have connective tissue disorders or other underlying conditions that put them at higher risk.
Okay, so I think our next question comes from Carl. Are certain patients more at risk of developing a CSF leak?
So just like we talked about, patients that have connective tissue disorders, which is sometimes difficult to diagnose as well, but there are certain questions that we can ask to determine if a patient might have a CSF leak. So for example, if they have very relaxed joints, or joints that are hypermobile, or they have had other issues with their heart, for example, or they've been seeing other physicians that have suggested that they may have a connective tissue disorder, it is something that we can verify and check. Usually it requires a referral to a specialist in the area. Often that might be a geneticist who does some genetic testing. So those patients for sure at higher risk. So those include, again, the more common ones: Marfan syndrome, Ehlers-Danlos syndrome, as well as polycystic kidney disease. And there's many spectrums kind of in between that as well, where patients may not have the fully defined syndrome, but they may have other types of connective tissue disorders that have some features of those. So if there's any suspicion of that, or if there's a family history of that, or a patient fulfills certain criteria in terms of questions about joints, questions about their heart, or other things, then I think in order for us to verify that, we would refer the patient to a geneticist to check that out more carefully, and hopefully have a more formal diagnosis. So those patients are definitely at more risk. Patients that have had head or neck trauma, also we have to be vigilant to see if potentially part of the headache that they have, because often they will have a post-concussive or post-traumatic headache, if that headache could actually be a CSF leak as well, versus just a post-traumatic headache. And we would use some of the same diagnostic features that we would normally look for a CSF leak to try and determine that. So for example, if there's a headache that's very positional in nature, or orthostatic as we call it, which means that the patient is much worse when they're upright and they're better when they lay down, then that might indicate potentially a CSF leak. So I think we have to be, again, vigilant to look for that, and to ask the right questions, and potentially do some imaging in patients that have had post-traumatic headache. So I would say that those are the big two groups. But spontaneous intracranial hypertension by definition is spontaneous. So typically we're not looking at patients that have had major head trauma, because that's sort of considered a different category, but definitely we do have to look even for trivial trauma in patients that have had minor concussions or minor motor vehicle accidents, that potentially could be a possibility. Otherwise, though, SIH can happen at any age. It can occur in children all the way up to the elderly, so there really isn't an age predilection to it. Women seem to be slightly at higher prevalence or have higher incidence of it compared to men, but again, there's nothing specific that makes them at a higher risk as far as we know.
Okay. Our next question comes from Krista. What causes the burning in the back of the skull and numbness on one side of the face? And is this a classic sign or symptom of CSF leak?
I wouldn't say that that's a classic symptom or sign of CSF leak, but definitely there are many neurological symptoms that can happen with CSF leaks. So patients do often have pain in various parts of the head, but particularly they will describe pain in the back part of the head or the occiput. And that can be mostly one-sided, but sometimes it can be, it's usually both side or bilateral, but sometimes it can be unilateral or one-sided. And the pain can take on different qualities. So sometimes it can be more like a pressure or a pulling sensation, and other times it can take on a burning sensation. And we feel that the headache happens because there's traction of some of the pain-sensitive structures that are involved in the dura itself, but also in some of the other structures that are being pulled down, such as the brainstem and some of the structures within the back parts of the brain. So the pain can take on any quality, and the burning on its own is not distinctive for SIH, but certainly it can happen in settings of SIH. In terms of numbness, people do describe numbness sometimes to various parts of the body. If it's more one side, it may indicate that potentially one side of the brainstem or some of the nerves on one side are being a little bit more affected, because it doesn't have to necessarily be equally affected in the brainstem. One side might be sagging or being pulled a little bit more, so that may be the case. So again, it's not classic for SIH, but certainly it would be in keeping still if we did see it with all the other features of SIH.
Okay. Ruth asks, do you also deal with cranial leaks and take referrals from out of province?
So unfortunately, cranial leaks are quite a bit more complex. And so typically as neurologists and with our team in Calgary, myself or my colleagues that deal with spinal CSF leaks would not typically be seeing cranial CSF leaks, but on occasion, we do have patients that have headache that get referred to us. Once a cranial CSF leak is diagnosed, typically the ENT physicians, ear, nose, and throat, or otolaryngologists, are the experts in that area, so we would typically refer to those specialists to manage, because often the management of that is more surgical. On occasion, if we do see a patient with headache, we can certainly help to manage the headache with medications as a temporizing measure while they wait to see an ENT specialist or as they're undergoing some of their surgical procedures. But it's typically not an area that we're experts in, so typically that would be the ENT specialist. In regards to accepting patients out of province, unfortunately, because we have such a high demand in our own province for headache, and we have a long waiting list of patients with headache that we're trying to work through and see. At this time, we're not taking referrals, but most large centers will have experts, headache experts that have some experience certainly with CSF leaks and SIH. And then the larger centers will definitely have the multidisciplinary team, such as Toronto, for example, Montreal, Ottawa, Vancouver. So most big centers do have some level of expertise, and unfortunately, in Alberta, in our case, because we do have a long wait list, we're not able to take patients out of province at this time.
Okay, next question comes from Jennifer. Why do people who have been fixed end up with sensitive brains, i.e., end up with pain from weather symptoms, or eating salt and certain foods, etc.?
So if I understand the question correctly, I think what is being asked is that if a patient has had a CSF leak repair, why do they end up continuing to have potentially some pain or some sensitivities later on, such as to weather or to food? So, I don't think that anyone fully understands this process, but what we theorize or what we feel probably happens is that once a patient has had an activation of their pain pathways, for example, with a process like CSF leak, but it could be from other types of headache as well, such as post-traumatic headache or even migraine that's gone on for quite some time. The central parts of the brain that are involved in pain processing get activated and become essentially hyperexcitable. And once that happens, sometimes it's very difficult to turn that switch off if you think of it as a switch being turned on. So even though the primary issue that initially caused the pain to occur, such as a CSF leak, has been repaired and that no longer is going on, that pain switch that's been turned on and those central activating pathways of the brain that are involved in pain doesn't necessarily get turned off very easily or very quickly. And because sometimes patients can have migraine-related features with the headache that they get, even with CSF leaks, sometimes they can go on then to develop sensitivities to the same types of things that a patient with migraine might have, such as certain foods, smells, sounds, or other types of things such as environmental triggers like weather. So we feel that it's most likely this process of central activation of the pain pathways in the brain that somehow get turned on, and then it becomes very difficult to turn them off. So sometimes we do, despite the repair of a CSF leak and the resolution of a headache that's associated with that, such as an orthostatic headache, in patients that have a residual headache, we do have to sometimes go on to use medications to try and treat the residual pain, and sometimes that can be helpful. Other times with time and just patience, these symptoms will improve. And unfortunately, there are a fraction of patients where it might be something that's more long-term.
Okay, our next question comes from Lauren. When rebound high pressure symptoms persist 10 months post blood patch and occasionally present as low pressure symptoms, do you begin to consider that the leak is not sealed?
That is one possibility. Although if the leak is not sealed, it's less likely for a patient to have rebound intracranial hypertension purely on its own, but certainly patients can have a mixture of the two at various times or on different days. So if there's still elements of what we call low pressure headache or orthostatic headache, where a patient is worse when they're upright and they're better when they're laying down, then that has to be a consideration of whether the CSF leak was fully sealed or fully resolved. And I think at that point, a reassessment by the physician would be helpful, and potentially re-imaging might be helpful. But in terms of intracranial hypertension on its own, that's something that can happen sometimes days, weeks, to even months after the correction of a CSF leak. And typically we would manage that with medication as best as we can. If it happens in a more abrupt fashion, sometimes we'd want to rule out other potential possibilities that can be a complication, such as venous thrombosis, which is a blood clot, for example, in the brain, although that's much less common. But sometimes we do have to think of that. So, once that's ruled out and the patient is defined to have intracranial hypertension, then medical management typically can be helpful, but it can go on sometimes for a number of weeks to months afterwards. So if there's a mixture of symptoms of both low pressure and high pressure, it certainly is worth reconsidering, reinvestigating to see if the CSF leak has been repaired. But the other thing to keep in mind is that sometimes, because there's a change in the dynamics of how the CSF flows in the brain and the spine, it can take some time for the equilibration, if you want to call it that, or homeostasis to return in the brain and the spine. So sometimes people can have some symptoms that go up and down for a while before things settle down.
Okay. The next question is from Linda. What type of pharmaceutical solutions do you typically use to treat symptoms in patients with unresolved long-term, let's say in years, leaks? And are they successful solutions? Thank you.
Yeah, that's a good question. So, unfortunately, because we have no specific studies on CSF leaks or SIH, for example, we don't have large clinical trials or database information. What we're doing often is extrapolating from other literature. So the medications that have had most success in other headache types, for example, migraine headache or other types of headaches, would be the medications that we would use most frequently, just because we know they have, in general, a better evidence based for those types of headaches. And by extrapolation, we feel that they're likely to be more successful in SIH or CSF leaks as well. So common ones would be antidepressant medications, for example, such as amitriptyline or nortriptyline, that we would work up gradually up to at least 50 milligrams daily. And these preventative medications take time to work, so we would at least want to give it a good 3 months period in order to see whether they're effective or not. But certainly other medications can be used as well. Sometimes we use anticonvulsant medications like gabapentin or topiramate, especially if patients do have features of migraine associated with their headaches. Sometimes we can use antihypertensive or blood pressure medications. And I have had some success myself with Botox for a few patients that have had CSF leaks with persistent pain. So it really depends on the patient because the success is variable. But in my personal experience, antidepressants such as amitriptyline or nortriptyline and Botox has been sort of the most effective of the different ones we've tried. But it is quite dependent on the patient. But certainly those can be options. And now we have very new migraine medications as well, such as Aimovig, which is a monoclonal antibody that blocks a protein involved in the pain pathway of migraine. And Aimovig is very new to us, but again, because it has had success, it has been shown to be successful in clinical trials for migraine, that might be another future option for patients that have persistent headache, especially if they have migraine-associated features with it, such as light or sound sensitivity, nausea, and aggravation by activity.
Okay. Next question from Ronnie. How do you approach patients with long-term classic symptoms of SIH with negative brain imaging?
Yes, that's a good question, and that's something that unfortunately we deal with more frequently than we would like because it does make things a lot more challenging. But about 15 to 20% of patients that have CSF leaks or SIH will actually have negative brain imaging. Sometimes that can be early on, and it can be even sometimes years later. So I think the key is to really go back and take a good history from the patient, especially early on in terms of when their headache first started, and determine if there was that orthostatic or positional change to their headache, because most patients, the majority, will have that, even if it kind of dissipates or changes over time. Most patients will have that at the beginning when they first start to have a headache. And also the other questions to ask would be, is the patient a lot worse when they're doing maneuvers such as bending over, lifting, coughing, sneezing, those kinds of things, and see if that makes a difference as well. So I think the history is key. So going back really and asking at the very beginning, how was the headache? Because we do know that the headache can often change over time, and it can become more of a persistent daily headache and lose some of that positional nature to it. And if it's a headache that's persistent, that's something that we need to think about as well. So in the headache world, we have a diagnosis or a term called new daily persistent headache, which basically means a headache that starts relatively abruptly over hours to days, and then it just persists. So that's something that is not classic for typical things like migraine headaches. So again, if a patient has a headache that starts in that manner and persists, I think we do have to be thinking about CSF leak. So typically if the imaging is negative, but if there's some history or features on the history to suggest that a patient could potentially have SIH or CSF leak, and if they've been in particular refractory or have not responded to other medications that we've used that we would typically use for that type of headache, then I think it would be reasonable to go on and try up to even 3 blind lumbar level blood patches, and some people will be brave and do them even a little bit higher, such as thoracic, and just see what the response is of the patient. If the patient does have some response, that is often helpful. But if there's no response, I think, and it's still a consideration on the diagnosis list, then we would go on to do further investigations to try and see whether there's some hints or evidence that we can find with spinal imaging. So typically what we would do first would be an MRI of the spine, looking at all levels, cervical, thoracic, and lumbar. And we do it in a specific manner called a heavily T2 weighted MRI, and the neuroradiologist would know this. And it's just a technique that's used to demonstrate CSF leaks a little bit better. And that would be the first test because it's non-invasive. And in some patients, it can be helpful to try and localize areas of abnormality or potential sites of a CSF leak. Depending on the results of that, if it's not helpful, then we would often go on to a CT myelogram, which is when an injection is actually done in the lumbar spine, with the idea that that would go into the area that there may be a leak, and there might be some evidence of that on the scan as well. So specialized CT scans, as well as sometimes digital subtraction myelograms, which are done for CSF leaks that can be very rapid. or it can be done in cases where we think that there might actually be a connection with a blood vessel, so CSF directly being connected to a blood vessel, or what we call a CSF venous fistula. So it would certainly go on to other investigations if the MRI of the brain was negative to begin with. Sometimes it's very challenging because even despite doing multiple tests, we still are not able to identify a CSF leak. So I think it's important at that point to think about the diagnosis again, because sometimes we are wrong in initially thinking that it might be a CSF leak, and there may be other headaches that might be mimickers. And these can include, things sometimes like neck-related headaches, or what we call cervicogenic headaches, so a headache that arises from structures of the neck. So it's important to do a good assessment of the neck and ask the patient to see a physiotherapist, potentially to do a very comprehensive assessment of the neck. And also other conditions that can look somewhat similar, such as POTS, or postural orthostatic tachycardia syndrome, which is a condition where patients can have changes in their heart rate, blood pressure, and other changes of involuntary control in the body that get affected, and with that they can have a headache that's much worse when they're upright as well. So I think it's important to, if everything comes back negative and the patient hasn't responded to at least the 3 blood patches that have been done, then to really reconsider the diagnosis. It still doesn't mean that it's not a CSF leak, but I think it's just important to think about those other diagnoses. And then I think you can go on to use treatment if necessary by that point, if the patient continues to have headache, and then typically reassess again. If it's still a suspicion, give it a bit of time, and then 6 months later, for example, reassess and again look for a potential leak.
Okay, next question comes from Vicky. Can hormones play a role in the cause of leaks? For example, raise intracranial pressure resulting in a leak?
Yeah, it's a good question. So in terms of intracranial hypertension, there's actually theories out there that many patients that end up developing a spontaneous CSF leak actually, to begin with, have intracranial hypertension. And intracranial hypertension is actually not as well understood in some ways in terms of how it first develops, but we do feel that there is a hormonal association, in that it's certainly much more common in women compared to men. It would actually be quite a rare diagnosis in a man to have this condition, but it has been described, so much more predominant in women. And it's also seen in women of childbearing years, so in the reproductive years when estrogen levels are high. So certainly we do think that there's an association with estrogen and intracranial hypertension. And then obesity and being overweight appears to have an association with this as well. So patients that are appropriate weight or not overweight, we would not typically see IIH in. That would be very unusual. So there certainly is a hormonal association with IIH, but if a patient is not obese or hasn't had really a history prior to their CSF leak suggestive of IIH, then we feel that the spontaneous CSF leak really has occurred spontaneously, separate from the process of IIH. So probably there are 2 categories of patients: those that have originally had a diagnosis of IIH, intracranial hypertension, that then went on to develop a CSF leak. And likely that happens from high pressure that's put on some of the dural areas that are weaker, and therefore a hole or a puncture can essentially occur in an area of dura that's weak, leading to a CSF leak. But then the second category of patients are likely these patients that we have that actually go on right off the bat to develop a CSF leak spontaneously without that prior IIH diagnosis. So I think there's probably 2 areas that we need to look at.
Okay. Lauren asks, do you see a relationship between CSF leak and dysautonomia? Dysautonomia. If so, what would be the mechanism that would cause a CSF leak patient to develop dysautonomia, automatic neuropathy?
Yeah, that's a good question. So as far as we understand, pure CSF leaks that occur spontaneously, or SIH, it doesn't seem to have a direct connection with dysautonomia or autonomic disorders of the nervous system. However, there is, of course, that overlap with POTS, which we referred to before, so postural orthostatic tachycardia syndrome, where patients do have that orthostatic headache similar to SIH, but they don't actually have a CSF leak. So I think, when there is dysautonomia, I think that POTS probably needs to be thought of in those cases certainly more carefully, and there's probably some overlap between POTS and SIH in terms of symptoms. But I think purely speaking, CSF leaks that occur spontaneously or SIH usually are not associated with a dysautonomia. So when we see patients that don't have those orthostatic changes in their blood pressure or their heart rate, typically that doesn't seem to be an issue where they have autonomic dysfunction. So I think that when we're looking at autonomic dysfunction, we're probably really dealing more so with POTS. So that's the distinction that we understand so far, but it certainly could be more complex than that.
Okay, next question from Larissa. Painful, tight and stiff neck and shoulder blade. How common is this in CSF leak patients?
That's a good question as well. So that certainly can be a common feature of patients that have CSF leaks, especially if it's been a longer standing headache. And that can happen just because patients, when they have headache, those muscles just tense up and get quite tight, and those are common areas involving the neck and the shoulder. So it can be seen quite commonly. So with that, we would recommend that patients seek physiotherapy if it becomes quite an issue, and to do regular stretching just to keep those muscles as loose as possible. Typically that seems to work the best rather than taking specific medications. But sometimes we would recommend things like muscle relaxants as well. Things like massage can provide some relief as well, but typically that would be more of a temporary relief. So we feel that if there is significant tightness of the neck or shoulder muscles, that physiotherapy, regular stretching, and good posture are kind of the most important measures to take.
Okay. Spinal CSF Leak Canada asks, what are some possible medications that can be used as temporary measures or perhaps more longer term if needed?
Right. So we did talk about some of the longer term medications that can be used, such as antidepressants like amitriptyline, as well as things like Botox if people do require medication for a longer period of time. But in terms of temporizing measures, we do sometimes use such things as a course of steroids, for example, prednisone, where patients are given a course for a period of 1 to 2 weeks to just help temporize their measures if they're having very disabling headaches. And that's variably successful, but when patients do have success, sometimes it can actually be quite effective for them, and sometimes it can relieve the symptoms for a number of weeks even after they've stopped the prednisone. And we don't know how something like prednisone actually works. It's a powerful anti-inflammatory medication, and it can be helpful in actually many headache conditions and many other medical conditions. In the case of CSF leaks, we don't know exactly how it works, but we feel that probably there is some sort of an inflammatory process, and part of the headache may be because of an inflammatory process that goes on in the areas of the dura and the brainstem. And so we feel that prednisone potentially might have a mechanism that way. But there are some other medications sometimes we recommend as well, including caffeine even. So taking strong coffee, but also caffeine tablets as pills can be helpful. In rare cases, some other medications such as theophylline might be used as well. So there are some medications that we can use as a temporizing measure. And then as we talked about, the long-term ones would be the ones that we've already discussed.
Okay. Nadia asks, what is the prognosis for healing for spontaneous thoracic spine leaks that are located ventral? Are blood patches sufficient to heal them?
Right. So unfortunately, ventral CSF leaks, regardless of the location, whether it be cervical thoracic junction, or thoracic area, can actually be quite difficult in terms of sometimes localization, but also in terms of treatment and management. In our experience and in the literature, it seems that these ventral types of leaks unfortunately do not respond very well to blood patches. I think it's still worth a try because there is a small percentage of patients where it could potentially be helpful, but in most cases, unfortunately, it's not helpful. So in those cases, if the leak has been identified, then surgery is really the best approach to that. And in most cases, once surgery is done, patients do have quite good success with resolution of symptoms. So typically in those cases, we would potentially try as much as possible to do a directed leak, but because blood patches are not done ventrally, they don't really access that area very well. So we feel that in most cases, patients do have to go on to surgery.
Okay. Linda asks, you have mentioned medications a couple of times. Can you tell us more about the medications and their success rates? Thank you.
Yeah, so, because again, we don't have large studies and we don't have large clinical trials, it's really difficult to put an exact number as to the success of the medications that we've used. So I can really only speak from personal experience and the experience of my colleagues that have shared this information, in that medications such as the antidepressants like amitriptyline or nortriptyline, as well as Botox injections, seem to have the most success. In our clinic, I would say that probably about a third of people that have persistent headache following a CSF leak have quite good success with it. About a third have some mild degree of improvement with the medications, and unfortunately about a third or so probably don't respond to the medications very well. And in those cases, we would look at using other things potentially, but sometimes we are unfortunately left with long-term pain. But as I mentioned, there are new medications coming to us in Canada, with the first one being Aimovig that I mentioned, which is a migraine preventative medications approved only for migraine at this time. But I think that probably, as we do with many other cases in medicine, we would potentially start to use such things, possibly off-label, to see if it can be helpful for patients with CSF leaks that might have in particular migraine type features to their headache. So hopefully in the future we'll have more possible medications, but I think really this goes back to the point that I was making initially, in that we really need to do more research in this area, and hopefully that will start with collecting data on patients to determine things such as this, what is the response rate to various medications for patients, and hopefully once we have more research we can be able to answer the question better. So that's as best as I can answer it at this point in time, but hopefully as we have more research we can give more specific answers to that question.
Okay. Larissa asks, can you explain please about the opening pressure? If opening pressure is lower than 10, why is there no exact number?
Yeah, so we can actually measure pressure anywhere from 0 and up, and even sometimes people can describe negative pressure. So below 10 is measured, so often we can say a patient has an opening pressure of like 2 or 3 or 1, or absent, 0, or even potentially negative. So it can be measured, but it can be more difficult certainly to measure low pressure because the CSF just doesn't flow out into the manometer, or basically the ruler that we use to measure the opening pressure. So I think that really with CSF leaks, the opening pressure is not all that helpful, especially if it's within the normal range. So if a patient comes in and has a history that's in keeping with that, I think regardless of what their pressure is showing, unless it's extremely high, which would be unexpected, then we would not really necessarily need to even measure the opening pressure, because we do know that many cases of patients that have CSF leaks actually have normal opening pressure. And I think it's probably because there's a number of things going on, but most importantly, it's a dynamic process. So patients, may have normal pressures at some points in time, but may have low pressures at other points in time. It may also be our technique. And we do recommend definitely that a patient be laying down on the left side, usually with the feet curled up initially, and then to straighten the feet once the opening pressure is measured. So sometimes it could be technique as well. But from our experience, we don't always go to an opening pressure, because we do feel that it's sometimes not helpful, especially if the pressure is normal. If it's low, it can be helpful to confirm the diagnosis, and typically low would be defined as under 6. But if it's normal, it doesn't necessarily rule out the diagnosis of a CSF leak or SIH. So in those cases, it's really not all that helpful. So we've actually gone away in our center, as many other centers have as well in Canada and the US, in terms of just purely measuring the opening pressure as a diagnostic tool. Unless, we really need confirmation of the diagnosis and we don't really have a good history of it, then we may want to do it if it's questionable. But as I said, because it can be normal, it's often not very helpful. So the only cases where we would often do opening pressure now is if the patient is already undergoing another invasive type of procedure where a lumbar puncture and injection is required, such as if they're going to have a CT myelogram or digital subtraction myelogram. We would in those cases go ahead and measure the opening pressure just for interest. But we typically don't do it just on its own, because we feel that it doesn't really have all that much value, especially if it's within the normal range.
Okay. Bahare asks, does a CSF leak have to be identified before a blood patch can be done?
So that's a good question. So no, a CSF leak doesn't have to be identified before a blood patch is done. And the reason for that is actually we found that in many cases, if we have a good history suggestive of a CSF leak, and if the patient otherwise has an MRI of the brain or a CT scan that is suggestive of CSF leak or even normal, basically we do that more to really rule out other types of diagnoses before we go ahead with a blood patch. So if the signs are there, it's definitely helpful, but as we talked about, 15 to 20% of patients can still have a normal MRI of the brain. So if there's a good history that the patient may have a CSF leak from the information that's been given in regards to their headache, then it's fine to go ahead with blood patches, and that's actually what we would recommend. When we reviewed the literature, that's the guideline that we came up with, in that patients can have, even up to 3 or 4 blood patches if necessary before going on to do more testing to look at the spine for the site of a CSF leak. And the reason for that is that many patients can actually have success with these, what we call blind or lumbar level blood patches. Sometimes it may be with the first one right off the bat, but sometimes it can be with a second or third one. So we do try up to 3 or so before we would go on to try to localize the leak. And that's also been helpful in terms of patients, undergoing less testing, undergoing invasive testing. So it's been helpful from that regard as well.
Okay. Larissa asks, if you're leaking CSF, does the blood volume inside your head increase?
So the overall volume does not increase. The overall volume actually stays the same, but certain structures of the brain try to compensate for that by increasing their volume. So overall, the intracranial cavity volume remains the same because it doesn't have the ability to expand any further because there's a rigid skull there. However, to compensate for the reduction in volume or pressure of the CSF, other structures will actually start to take up some of that space. So things like veins, for example, so we have dilatation of veins that can happen in CSF. Certain glands, like the pituitary gland, can actually look more plump and take on a little bit more volume. And sometimes people can have other collections of fluid in the brain that can occur over the surface areas of the brain, and that can be either just fluid-filled areas in the brain, or it can be even blood potentially in some cases.
Okay, the next question is quite interesting from Vicky. Can I ask your opinion on why most doctors are reluctant to pursue a leak, especially with a negative MRI, or research the latest findings/diagnostic tools available to them? Thank you.
Yes, I think, there's a lot of education that still needs to be done, because I think many people still believe that if the MRI doesn't show signs of a CSF leak or any signs of SIH, that patients don't really have a CSF leak. So I think that's where part of the reluctance comes from is that, we still need to do lots of education of our colleagues to, let them know that, again, 15 to 20% of patients with a normal MRI of the brain can still have a CSF leak. I think it's also difficult because, not all centers have the expertise, such as specific neuroradiologists that would know, what type of scans to do. And also, it becomes involved in the sense of invasive testing. So again, there's reluctance on that part to do, much more invasive testing if there's not a lot of evidence for a CSF leak. So I think really it all has to do with education, in that, I think we just need to do a better job raising awareness of this condition, and that's why we do videos like this. But also educating our colleagues in terms of, what still could be a CSF leak even with a normal MRI of the brain. So I think there just has to be a very high degree of clinical suspicion initially, and then a persistence to pursue it, even with negative imaging, if there are historical features from the patient's history that suggests that it could be a CSF leak. So I think part of it, unfortunately, is education. Part of it might be resource issues or lack of expertise within a specific center.
Okay, well, Jennifer has a related question. Generally speaking, what is the level of awareness of this issue in Canada amongst those in the medical field? Is it accurately diagnosed? Is there enough research being done in the field? Is this being discussed at conferences?
Yes, so certainly at conferences we do discuss the topic of CSF leaks and SIH very commonly. There is the Canadian Neurological Sciences Federation meeting that's held annually. There's the American Headache Society meeting that's held annually. There's many courses across the US that's done on a yearly basis, such as the Scottsdale Conference. as well as international conferences like the International Headache Society. So essentially every year at some point CSF leak and SIH is discussed. Unfortunately, the problem is that general neurologists, which sometimes see lots of headache patients, aren't necessarily at those meetings because they're more geared towards patients as well as experts in the field of headache. So if it's a neurologist that doesn't have a subspecialty in headache, they may not necessarily be able to attend meetings such as this. But we do try within our own centers, such as the University of Calgary, to do rounds, presentations, and other educational events where we do raise awareness. But I think we just need to do more so. In terms of Canada, I think again, if it's a larger center where there is available expertise, in most cases it's not something that gets missed. I think it often is looked for and assessed. And then if there is suspicion from general neurology or other colleagues, they would refer to a headache specialist, such as our clinic in Calgary, but other ones in Canada, as we discussed, like Vancouver, Montreal, Ottawa, as well as Toronto. But with the smaller centers, I think that becomes definitely a lot more difficult. So I think it's just trying to get the message out there in different ways through, for example, organizations such as the Canadian Spinal CSF Leak Organization and the American one. So I think we just need to continue to raise awareness and provide more education.
Okay, so I think that answers Man Levy's question, what can be done to help Canada advance more in this area? So I think you've done an excellent job addressing that question. So hopefully that previous statement from Dr. Amoozegar covers that question. Question from Justin Forza. Why does a leak cause superior channel disease syndrome or SCDS?
So I'm not sure what's meant. Would you mind clarifying that? So maybe we'll go on to another question before we come back to that.
Right, so I'll go. All right. So Man Levy asks, do we still refer patients out of the country for treatments, or are we equipping Canada to treat complicated cases of leaks?
So I think for the most part in Canada, we are generally equipped to deal with some of the complicated cases. Vancouver, Toronto. In particular, Toronto, they actually have a whole team involved there. So they're probably the biggest of all the centers in Canada for dealing with CSF leaks. They do have an anesthesiologist, Dr. Philip Peng, who's quite an expert in the area and has a special interest, as well as expertise in neuroradiology and neurosurgery. And the neuroradiologists there have actually trained with Dr. Shivink in Cedars-Sinai, which is kind of the most one of the largest centers, as well as Duke, that are the largest centers in the US for dealing with CSF leaks. So in most cases, I think we do have the expertise, but there may still be, a few cases that are much more challenging to us or more complex in some way that we may want to refer to the US. And I think, that becomes challenging, of course, because we do have to often apply for a large sort of out of country or out of province application for that. But it can be done, and I have done it myself as well for a few patients.
Okay, Emily Pickford asks, for a spinal CSF leak, is it normal to sweat along the spine of the back of the neck and on the head, and why?
So I wouldn't say that it's a common symptom to have sweating in those areas, but I have seen a few patients describe that. I think that, when patients do have pain, some of those pathways that are involved with other things that, deal with the nerves, such as sweating, heat, or other types of sensations can also occur. So I think it's just probably some activation of the other nerve pathways that are sort of concurrent or close to the pain pathways that are involved. But it's not typically a very common symptom. Okay.
Justin asks, if a spot above your former leak develops, is this a pool of CSF?
So I think that's a very specific question that has to be answered in the sense that I think it could be or it could not be. So I think it really requires imaging and some assessment by the neuroradiologist, because sometimes pockets of fluid can form, especially in certain parts of the spine, such as the C1-2 level, where actually it's been described as a false localizing sign where fluid can collect. So I think it just really depends on the location of the leak, the location of the fluid, and what it looks like on the scan as well. So I think at this point in time, we thank you for your questions. There's been lots of very good questions, but we will have to start to wrap up our session here. It's been very nice to be able to answer your questions. Thank you for your interest. Thank you for allowing us to raise awareness. Thank you to Spinal CSF League Canada for raising awareness and setting up their website, as well as hosting us for the live Meet the Expert event. Thank you so much for joining us. We hope to be able to do this every year during CSF Leak Week, where we can again raise awareness. So thank you so much for joining us today. We hope that it was helpful for you. And I just want to again thank you for having us do this session with you. And thank you to Canadian Spinal CSF League Organization. Thank you so much.